Yeah, we run a little bit long here, but Lee, Eco, come on up and we'll have an attenuated discussion. Just keep your questions concise and we'll try and keep our answers concise. And if we don't turn the microphone on, it's going to be very...
Yeah, it's working now. It's working now. Good. My question is for Lee. All the surgeons that don't do POEM are trying to kill POEM due to the reflux somehow, and we get all, in every meeting that we present POEM, we get that back. What do you think about the asymptomatic, how do we need to deal with the asymptomatic reflux in POEM? Because a lot of surgeons are saying that you cannot, leave patients with reflux, with that 38% that you show in the pH, without endoscopic findings. I'm not talking about endoscopic positive findings. I'm talking about pH positive, endoscopic negative, asymptomatic reflux, and how
we get it.
Yeah, I think you test them and you treat them. We have a lot of those patients with minor reflux on H2 blockers, and they're happy to do that. And some of the rest are on PPIs. And if they don't want to be on PPIs, they can have an anti-reflux procedure.
Are you concerned on long-term for that?
Long-term medical use? Long-term use of
long-term exposure.
H2 blockers? Not a whole lot. I mean, these patients came to you for dysphagia relief, and I think that's kind of where you are.
All right, fast and furious. Prakash, you gave the talk, but there are a lot of other people here who can answer the question. MRS, rapid drink challenge, food challenge. You got a technician, a nurse practitioner doing your study that you're not going to see. How do you decide to be practical in a 1 RVU study? Well, that's reality, and I think that that's worth talking about for 30 seconds from Peter and Christy, as well as you.
So I will say that in our lab, we do MRS and rapid drink challenge in every patient because the nurses have gotten to the point where they can do these rather quickly, and the gain in trying to further refine your 10-swallow diagnosis seems to be higher, especially in EGJ outflow obstruction.
That's an unfair answer. What about for people who don't have your nurse who can do it quickly and patients who hate it?
Maybe somebody else?
So yeah, that's the reason that I haven't made it a protocol. But I think we can train them. The other easy option is just to give every single one at the end of their study an MRS. And we've been toying back and forth. But there's no way that we're going to put somebody in the manometry lab to have a meal and sit around with a tube in their nose for half an hour. There's just no way.
That we don't do in every patient.
Okay. But to his point, your nurse makes the decision live, right? Based on what you find. So I think it's a good question.
That's all right. I'll fight you later.
We think that more is better, so we do it all.
My name is John Gabrielson from Geisinger in Danville, Pennsylvania. This is for Lee with regard to POEM, specifically with hypercontractile motor disorders, but a manometrically completely normal LES. Do you leave the LES alone? My chest doesn't talk. Do you leave the LES alone, or do you do a standard POEM, go all the way across it?
Yeah, I think if you kill the body of the esophagus, you have to get rid of the LES, or for sure it'll have progressive dilation.
Yeah, that's a recipe for disaster.
So this is for Prakash. So one of the things I see published as well as what you showed, type 3 achalasia. The onset is simultaneous, but the peak and the end of the waves are always peristaltic. And we published a paper last year on that. So what do you think? I mean, is it peristaltic or is it simultaneous? Because it has huge implications. Because if you're going to call it simultaneous and you're going to call it achalasia, then it's an automatic treatment, thinking would be Heller's myotomy. But that's not what works. And, based on, I've been following this for a long time, I think this was the same entity. We called it diffuse esophageal spasm in the past. And we did long myotomy for those. Short myotomies did not work for. So this is important to say, what are we dealing with? Because I don't hear that.
I think your point is well taken. I think what you're seeing in that setting, the real type 3, is that you have an error of inhibition. It's not all going to be the same. You know, there are going to be varying degrees of involvement. And so,
And the other thing, I think we got to be very careful about this latency, because in the setting of simultaneous onset contraction, you really cannot define the latency. And if you're going to rely on the latency, I think that's inaccurate.
But you can have, latency doesn't miss simultaneity. Simultaneity may miss latency, or maybe it's the other way around. All short latency swallows are going to be simultaneous.
So, but this could be just simply outflow obstruction. So it's very difficult to define latency in this setting of simultaneous, whether it is pressurization or it is some artifact.
Well, you can tell those things apart, Ravi, by the vertical pressure profile as to whether or not it's flat or whether or not it has multiple peaks on it. It is a challenge, but it can be done.
I really don't think one can.
I think the 2019 paradigm is that you're going to go for a poem in many of these patients. That is the tailored procedure. So especially if you're convinced that what you're dealing with is a disorder that involves both the body and the LES. On the other hand, if what you're seeing is compartmentalization in the esophagus and not really true premature sequences, I agree with you that all you need is to resolve the outflow obstruction. So I think that this is not a very clean category. There is heterogeneity, partly because we don't always look at these studies correctly, and because the disorder itself may not look exactly the same when you
Yeah, for the experts like you or Peter, it's fine. But out there in the world, once you label somebody achalasia 3, then automatic treatment is Heller's myotomy.
No, it isn't,
Pneumatic
actually.
dilation.
No, it isn't. Actually, the automatic treatment would be a poem at this point in time.
So whatever, yeah, so you can, but that's important point, that you have to extend the myotomy all
Sure,
the way.
because you have
close
distal
to the-
esophageal obstruction. Yes,
But in type 2 achalasia, you don't have to do that.
that's correct, too.
Yes.
But type 3 is not achalasia, that's what I'm trying to say.
well, it doesn't matter what we call it, but the treatment is POEM for the outflow obstruction you see in that pattern.
Yeah, hi, Kevin Gillian from Alexandria, Virginia. Since we were talking about Chicago classification, and I have Dr. Swanstrom trapped in a chair, and I'm a surgeon who also has a motility center, what do you think has changed in your workup or your decision tree in the last, let's say, five years with the addition of Chicago classification? In other words, if you took the same patient today, saw the same patient 10 years ago, has the addition of this classification scheme changed your management of specific patients surgically? I don't mean just achalasia, but I mean motility issues that you would have done in Nissen, now you do something different, et cetera. Has it really made a difference? There's a lot of data, there are a lot of names that change every couple of years with respect to Chicago classification, but has it made a on-the-ground difference in how you as a surgeon manage your patients?
Yeah, I mean, I think that's a fair question, and it gives rise to interesting debates like this in conferences, but for a pragmatic application, it hasn't changed a whole lot.
One way it has changed, it has dramatically increased the diagnosis of achalasia.
I agree.
So whereas you used to have the incidence that Lee mentioned of 1 per 100,000, in 2 centers that have utilized high-resolution manometry, that has multiplied by almost a factor of 3. So it's closer to 3 per 100,000. That's all an effect of high-resolution manometry.
I also think we're getting closer to understanding the disease more and kind of the sequence of the disease, and that's totally thanks to high-resolution manometry. And that's going to lead to new treatments down the road.
Yeah, but I'd say it's had an impact in a disease that has a very low frequency. But in terms of day-to-day management of our reflux patients, and
Nope.
not much.
As the beginning of my slide says, we just disrupt muscle. That's all we can do.
I'm going to take this pause as an indication that we're ready for dinner. Reg, are there any specific